Well, good afternoon and welcome. My name is Kelly Pfeiffer. I'm with the California Healthcare Foundation, and we're delighted to welcome you to our webinar where we've invited Dr. Cory Wyler to present on Addiction 101, what neurobiology teaches us about the impact of long-term opioids on the brain and how it changes our approach to treatment. Cory Wyler is a Senior Medical Director of Education Policy at the Camden Coalition of Healthcare Providers. He's been working with the Foundation now for over a year as faculty in our various projects and medical education efforts. He came from Spectrum Health, where he led a very innovative complex care clinic that got national and international attention for better outcomes, better experience, and better care, lower cost for people with substance use disorder, mental illness, and other complex conditions. California Healthcare Foundation, for those of you who don't know us, is a philanthropy that's been dedicated for the last 20 years to working on our healthcare system to ensure that we have healthcare that works for all Californians, especially those who are low income. One of our big initiatives over the last year has been working on the opioid epidemic, the one epidemic that's caused by our healthcare system, but that the healthcare system and our community together can fix. We are optimistic that together we can turn this around, so we're no longer seeing the opioid deaths and the addictions and the poor outcomes that have currently been so front and center in our own patient experience and in the news. I think all of us on the call have had some personal experience with a loss from the opioid epidemic, whether family or patients, and so this really drives their commitment to making a difference. I'm a family doctor, and I used to work at a community clinic that had a high population of people with chronic pain, and then worked at a health plan in San Francisco, and now I've been at the foundation for a couple of years. And we really see this problem as something that needs a system approach to fix. So if you look at our website, we have publications on the roles of health plans, on what community clinics can do, both in the area of addiction treatment and complementary care, how you can integrate medication addiction treatment into primary care clinics and in the emergency department. So we've got a wealth of resources and events, so do please look at our website and we can orient you. Next slide. This presentation, we expect a lot of participants, so we've got over 250 registered, so we won't have any live questions, but that's what the question box is for. Please do feel free throughout the presentation to ask questions, and we'll tee those up to the end. Any questions that we can't address during the presentation, we will send answers through an email next week that will include the slides and a recording and any potential resources that could be helpful. So if you have a logistic or technical question, use the chat to the host. Questions for Dr. Wyler, send to the question box. And again, we're happy to make sure that you get a copy of this next week. And we do ask you to complete a survey at the end so we know how we're doing. Next slide. Just a little example of the events that are available. And again, if you go to our website listed at the bottom, chcf.org, Opioid Safety Coalition Network, we've got several offerings. We've got one that's actually done by the CDC there's a CDC series going through their recently released clinical guidelines. We've got a webinar on how to spread the word on communication training, and then a really interesting webinar on how to use the zero suicide death model to, and how to apply to zero overdose deaths as a framework that organizations can use to drive overdose deaths down to zero. Next slide. So now we're going to switch over to Dr. Wyler, and I just want to say how listening to Cory speak has completely changed how I think about long-term opioids and addiction, and that's why we've brought him back several times to speak at our events. And he's got a very unique understanding of the problem, both from his initial training in neurobiology, as an emergency room doctor, as a pain specialist and addiction specialist, and very compelling public speaker. So I welcome Cory Wyler, and thanks so much for joining us today.
Yeah, not a problem. Thanks for having me. So first, I guess we'll run through some of the basics. So disclosures, I get a salary from Camden Coalition, Healthcare Providers, and I have grant funded through the Robert Wood Johnson Foundation for development of an online training website, and nothing else to disclose. I have no pharmacy, therapeutics, or drug company-related benefits coming my way. So today we're going to approach this a little differently. So instead of starting with a conversation about the addiction piece of this, we're going to really start to we're going to start with pain, because that's where patients normally start. They'll show up and say they have pain, and we may perceive something different, but rarely do they have the insight into early addictive disorders, or if they do actually have pain, do they really fully understand the implications of the ways that we have in the past and even currently treat pain and what that can do for them long term. So we're going to talk about how the brain approaches pain, and hopefully by the end you'll be able to kind of understand how opioids affect how the brain reacts to pain, and then how chronic opioids can lead to addiction, and then understand the neurobiological overlap between pain and addiction. So part of that is going to mean that I'm going to have to talk about everybody's favorite stuff, which is the pain pathways. But let's start with just kind of the lay of the land. So the lay of the land here is you can see a brain, and if you look at the green, that's the anterior, the front part is the anterior cingulate gyrus, but that's just the cingulate gyrus, and the multicolored with red, green, and yellow is different nuclei within the thalamus, the relay station. The gray part is right here is the ventral tegmental area. This is the nucleus accumbens. You have the amygdala, periaqueductal gray, and this is just cranial nerve number 5 that modulates some of the facial pain syndromes. But these are the general pieces of the brain that are responsible for how our body relates pain, and obviously the spinal cord plays a part, and we'll talk about that in a second. But one thing that I want you to understand, and we'll see this later, is that this is also the chief anatomy for addiction in the brain. If you just remove the thalamus, you now have the components of the brain that are generally responsible for addiction-related disorders. So pain and addiction have this really interesting overlap, and sometimes it's a difference without a distinction. And we'll talk a little bit about how to take a patient who has chronic pain, who's been on opioids, but their behaviors are maladaptive, and what that really means. And does it really change the pathway of treatment or not? Is the treatment the same, even if they don't fully meet for addiction but start to have these behaviors? And what has been started to be labeled as more of this complex dependence, more so than an opioid use disorder or all-out addiction. So if we talk about pain, right, this is the diagram that it took me forever to really commit this to memory, and then I realized the reason it did is because it was never taught to us in a way that is easy to absorb. So I'm going to try that, and if I fail at it, please feel free to give me feedback to that effect so that I can make it better. But we have 3 basic tracks, right? We have the ascending track, which really is 5 tracks in one, and then we have the 2 descending pathways, ones that inhibit the signal and ones that excite the signal. So there's one signal to the brain and a gas and a brake pedal coming from the brain. So if we look at the red one there, the ascending pain signal, it's broken into 5 different groups, and that's the spinal thalamic, spinal reticular, spinal mesencephalic, the spinal hypothalamic, and the cervicothalamic. And everybody's like, oh my God, here we go. We're going to go down this again. And I'm going to focus on what I call the 3 amigos, which is really the spinal thalamic, spinal reticular, and spinal mesencephalic, because these are the 3 pathways that are responsible for the clinical attributes and behavior of patients that we see, and try to help you understand why it's important to know how these manipulate pain, perception of pain, and then behavior. The other 2, while they're important, they're less overt in what they do, and so we're going to focus on the other 3. So let's run through what's happening. So the somatosensory cortex is another piece, and that's what tells us kind of where we're having pain is. But that gets signaled through the same spinal thalamic tract. It comes up to the thalamus and then pops out to the somatosensory cortex up at the top and tells us where it is. Now you see all these different little red offshoots, and that comes out to the prefrontal cortex, anterior cingulate cortex, and this is more of the emotional component. You see the amygdala here. So the important thing to understand between those is you have the spinal thalamic tract is purely for location of that pain that it needs to be dealt with quickly. The spinal reticular tract is the thing that makes us awake about the pain. And that's important because people with chronic pain continue to get signals through the spinal reticular tract, and that tract very specifically goes to the part of the brain that's responsible for our sleep and wake cycles. And what we need to understand is that the sleep and wake cycles become important for long-term behaviors. And those long-term behaviors that we see are those that are sleep deprived. And if you have continued chronic pain, then that spinal reticular pathway is sending a signal to the part of the brain that's keeping you awake when you should be able to go to sleep. And then you have the spinal mesencephalic, which actually becomes important for the opioid pathway, because that's the one that really turns up the internal opioid or endorphins, so that we can make sure, that we ultimately make the products that should be helping our pain. But what we also find is that if that becomes dysfunctional, then the spinal mesencephalic pathway becomes useless when we start using opioids. And so then all we have is something that keeps you awake and something that gives you a pain signal, rather than the one that can actually help to create and produce opioids and send those back down and turn on the inhibitory pathways and then work in the spinal dorsal horn. So again, just to review, so it all sticks in the brain and we all walk away neuroscientists is you have the ascending tract that sends the signal, spinal thalamic, which basically locates your pain and tells you really fast where it is, spinal reticular, which keeps you awake so that you don't fall asleep while you're sitting on a tack, and then the spizomesencephalic, which ultimately helps us to make our own opioids or endorphins internally. And then the other two coming down, which is the descending inhibitory signal, which is the body's way of turning down the pain intensity, and then the descending excitatory signal, which is going to turn up the intensity, such as if you burn yourself in a small area and all the way around that by 3 inches away from the burn, you have this hypersensitive area. So it actually turns up that signal and allows it to be a much brighter signal than is what's coming in. So it's the amplifier of pain rather than the one that turns it down. So let's talk about the normal response with kind of somebody who has a high or average pain tolerance. So you have an acute on chronic pain, and I'm going to talk about patients who already have chronic pain and then they re-injure themselves. And specifically, let's talk about the most common one, which is this chronically painful back. They were lifting something, they felt worse pain, and they come to your office or to the emergency department and they're complaining of this acute on chronic pain. For someone with a high to average pain tolerance, they will initially emotionally assess what's going on. And again, that comes through the spinal mesencephalic and a little bit of the spinal reticular, but mostly the spinal mesencephalic. And if emotionally they assess it and it's all good, then what happens is we get this increase in the descending inhibition. So we get an increase in the pain control because it pushes down on the brakes. And ultimately, you get a decrease in the ascending pain signal. So you get a decrease in the spinal thalamic tract. So you're decreasing the signal going to the brain that says you have pain, and you are increasing the brakes down at the spinal cord. So ultimately, when all that's happening, we're producing endorphins in the periaqueductal gray and in the dorsal horn, and that's helping those brakes to work and to last for a while. And this is how it would normally work. So this means that we're going to have less pain and greater function. So if you twist it and you have no significant emotional reaction to that other than a little bit of anger, and then all of a sudden you look around, you're like, okay, I can move, I can walk around, it's not a big deal, then the body is going to increase the brake, which means that it's going to slow down the pain, and your body's going to produce its own endorphins. You're going to take a little break, and you're going to walk away. And that's a normal response to pain. Now let's talk about the person who would have what we would consider a low pain tolerance. And this can be genetic, and it can do with these areas in the dorsal horn called the polysynaptic interneurons. And these are the things that are the interconnectors between the different signaling pathways. And this is also where our NMDA signaling lives. So this is ketamine in our spinal cord that really helps to modulate how we either increase or decrease the pain. And some people have a lower tone, and so therefore they will perceive pain that is the same quality and character more than the person next to them. And so basically they have a genetic risk of a lower buffer. So if you have two people sitting next to each other and one gets poked with a tack and they say, all right, that hurt a little bit, but they had that normal response, This is the person who you poke with the tack, and an hour later they're still rubbing it and like worrying about it and almost really emotionally integrated into this pain. Well, that's a person who we would define as having a dorsal horn defect, and in many ways we call that fibromyalgia for patients in an extreme version, or patients with a low pain tolerance in just the mild version. So for that patient, you have this acute on chronic pain. They emotionally assess it, and it's not all good. They emotionally intensify themselves around this pain. And we could go down a whole tangent of how this happens in patients who've had significant pains in the past, or PTSD, or early life trauma, and how that even modulates it and makes their emotions more available to the pain signaling pathway. So some people can turn it off. My dad was a force recon Marine sniper, and they were trained very specifically to have pain not be an emotional thing. Pain is just pain. Pain is just pain. So you can train that in. But then you have some patients who get the opposite of that, where they have early life trauma, they have repetitive emotional anxiety, and then those things actually make it to where pain is mostly emotion. And they can have very little actual nociception or cause of pain, but in the end have a 10 out of 10 pain that they describe. So this person emotionally assesses, it's not all good. They start to embody those portions of the brain that we showed, which is the frontal lobe, prefrontal cortex, the anterior cingulate gyrus, the amygdala, and then what happens is you get this increase in the excitatory pathway that goes down. So they're pushing on the gas. So they're taking what was a mild to moderate pain, and their brain is now turning it into a severe pain. And when they decrease in that, and they're decreasing the brakes, so they're pushing on the gas, pulling off the brakes, and they're turning this little bitty thing into a much bigger event than it needed to be. So this is also followed by this increase in perceived pain, and then in many cases a version of hysteria and tachypnea. Now the tachypnea is interesting because this is the body's backup system to help them still treat this pain. And if you watch these patients have their pain-based panic attacks almost, they become tachypnic. They become tachypnic enough to where they decrease their carbon dioxide load. When that happens, it changes the pH. That actually acts as a peripheral signal for the periaqueductal gray and the dorsal horn to release, as well as in the medulla where the respiratory center is, to release the endorphins, because that will help to slow the respiratory rate, but also indirectly help their pain. And so it may take them longer and through a different pathway, but ultimately that whole panic attack helps to compensate for their lack of immediate treatment of that pain that you would have in an individual who has a pretty normal genetic anatomy within that dorsal horn. And so this is, if you watch the pattern, you'll find that it is pain, panic, tachypnea, then a slow relaxation, and then mostly a cessation, but it takes an hour where the other person may take 2 minutes or 20 seconds. So those are the two ultimate normal responses that you're going to see. And I call that normal because these are patients that aren't even on pain meds. These are patients who just have their own way in which they deal with the pain that they have, and they approach it from the thing that fits them best. And that's why we would ultimately say, well, that person has a high pain tolerance or low pain tolerance. So there is actual science behind it, and those are the pathways. So now let's look what happens when we add opioids. So in general, what happens is when we give somebody an exogenous opioid, we write them for morphine or we write them for Dilaudid, what's going to happen is you're going to decrease the production of the endogenous opioid. So, all of those things in our body, the enkephalins, the beta endorphins, and the dynorphins are going to be decreased in the amount that they're produced, because the body is sensing that it already has enough through the feedback mechanisms that sit in the periaqueductal gray, as well as in the dorsal horn. So you're not going to be making, in the short term, you're just not going to release as many opioids. But in the long term, you'll actually decrease the production of it, to the point where it takes a long time to ramp that back up. So the body also does something, it fights back, because it needs to give you positional information. So if you're sitting too long or standing on a foot wrong, or any number of things that the body needs to be able to give you basic positioning feedback for, it can't do that anymore because it has the opioid. So it ramps up all of the signals for where you're sitting in space, which means it turns on all of those alpha fibers that are myelinated, those really fast fibers that send pain signals to the brain. And so now they're basically sitting on edge, and any little thing can set them off as compared to the requirement for a much larger stimuli that would have set them off in the past. So what's happening now is you're now going to get a greater signal from the ascending tracts, meaning all of those, the spinothalamic tract, so that's going to give you a much more intense location of pain, and it's probably going to widen that location of pain. And so if it just normally hurt in the lower back, you'll have people describe their whole back, the whole thing. And you could touch it anywhere on the back, and you could barely go, barely push on it at all, and they'll have a reaction to that, and otherwise known as hyperalgesia. The spinal reticular tract is also spun up in this situation. And when that happens, that's when you get those significant sleep disorders that you find with opioids. And it's not just the disordered central sleep apnea stuff. You actually get very disorganized sleep a lot with this, because the spinal reticular tract is ramping up to try to overcome the opioid, which means that it's centrally trying to wake you up every so often, more than you normally would, and you lose your internal clock. The spinal mesencephalic one is also doing that because it's decreasing the release of those opioids or endorphins that are sitting in the periaqueductal gray and the dorsal horn and the medulla. And so those are things that are happening as each of those systems spin up. You're having those side effects. And all of those side effects mimic what people complain about when they call it pain. But in many ways, it's actually the treatment of that pain that's causing those side effects to happen. And most people on this call at some point or another have had a patient where they've written them for opioids, and they come in as a 10 out of 10 pain. You write them for opioids, it gets better, the body compensates, and 2 or 3 weeks later they come back and say, that dose isn't working anymore, and so the body cranks up, and then we just continue this pathway, and that's AKA tolerance. And so as these things happen, we add more opioid on top. They then produce less opioid again. The body then ramps up the spinal thalamic, the spinal reticular, and the spinal mesencephalic, and then from that we start to get this really disproportionate abnormal response, which leads to a much more emotionally labile person, because the opioid is affecting the limbic system in ways that disinhibits our ability to react. And so in many ways it's like having one too many drinks, and you're saying and doing things that you wouldn't normally do, and those are not always positive in this setting. So that's the general aspect. So let's talk about that same person who hurt their back. So this means this is going to happen. So a person's going to emotionally assess it, but because of their inability to really emotionally normalize, they're going to say, well, is it good or is it not good? They're not going to really be able to make a decision about that, but they will jump onto the strongest emotion that they have, and usually that is a more negative emotion, because of the part of the brain that it lives in is less affected by opioids. So anger and sadness are more likely to come out because they're not as suppressed as an emotion by opioids. And so we now see this increase in the descending excitatory pathway, so meaning we now push on the gas because they're trying to overcome the outside opioid, so it's going to now have to do it even more when you have this new injury or rotation. And then we have the decrease in the inhibitory pathway given the presence of the opioid, and that's basically taken off the brakes. So now we have this disproportionate utilization of something exciting or worsening pain, and then somebody taking off any of the brakes that are there. So now we're basically going downhill, no brakes, fully on the gas. So this increase in perceived pain followed by the hysteria. However, now the tachypnea that would normally happen as the backup, we've blocked that because the opioids are blocking the respiratory center and the medulla. And so something that we know occurs in very high doses of opioids and is responsible for the overdose, we're now seeing just as a baseline, stopping the body from compensating, and it's kind of its last stop effort, to really take care of that pain. And so they're not going to get the change in the pH. There's not going to be an increase in the amount of endorphin. So not only are you not going to release more of it as a backup, but you're already producing less. And so with that, they have a panic attack, and the pain's still there. And in many cases, it gets worse. So it gets bigger and longer and this. And so now you're also getting this intensity from what we call the slow fiber or the C fiber. It's not myelinated. And this is also responsible for the kind of the widening, more visceral type pain. So they're going to start to call this more ache and instead of being able to localize it, and they probably won't even be able to really describe it. So once you start to involve a large number of the C fibers in this disproportionate system, then you're going to end up with people who can't describe their pain, but they will tell you that it's something that they can't sleep at night, they can't get comfortable, and nothing is okay. And all of that is explained based on the way in which we treated the initial pain, which worked great in the acute phase, but once that starts to move into the chronic phase, the body does not know what to do when we continually give it exogenous opioids. So this leads to all of that physiology and neurobiology. Really, we don't see those. We can't look through their spine and watch that signal happen. So the way in which we, see this is in behaviors. So we see their behaviors change in a number of different ways, which we'll talk about. We also see, issues with, quote, medication, right? So these are little early refills, maybe overtaking, maybe chewing it instead of just swallowing it, any number of things. And then we'll find some physical characteristics where their body is now responding to a pain that actually isn't there. So they're getting a signal that there is an injury, but really it's just the overzealous spinothalamic tract sending a signal to the brain. And instead of brakes, there's just gas. And so it's taking what would be a normally small area of pain that may have been due to an injury at some point, and now it's making it feel like it's this entire part of the back. And so they will start to have the physical characteristics of this, which are, they will start to favor those areas. And then if they do that long enough, you start to see atrophy in certain areas because of disuse. You can see changes in weight, either increase or decrease because that little tract we didn't talk too much about, the spinohypothalamic tract, goes to the hypothalamus and can actually increase or decrease glucose tolerance and increase craving for carbohydrates. So they actually, in this chronic pain state, from this feedback loop, can actually increase the desire for a Krispy Kreme and eat things like that. So they start to gain weight, lose muscle mass, and get atrophy. So we get into this snowball effect of this chronic pain of a patient on these opioids. So if we get more specific about what do these behaviors look like, well, if you're in the emergency department or your office or on the floor of a hospital, this is what you see. You have a patient who seems to be really calm, and then the next minute they're having a complete freaking meltdown. And they're screaming at, who's this? I want to talk to your boss. I want to talk to this. And I don't know, you hate me, and I'm suing everybody. And they just go completely off the handle. And then they just slip back. And then they're completely unaware that any of this has happened. And these are the people in your office who they drop their keys while they're talking to you, and they have like an emotional meltdown because they dropped their keys. It's not that they lost their keys or their car was stolen or the sun imploded. It's they dropped their keys on the floor, and they have this huge emotional reaction to very tiny things. And then you have this irrational thinking or behaviors where they're like, well, if you're not going to write me for these opioids, I'm just going to go use heroin. And to me, that's, and those patients automatically get labeled as addicts, but really it's starting to get more into this gray zone of behaviors, whereas they're just completely irrational because even if they go to sleep, they're losing a lot of their delta sleep, so they're not getting their deep sleep, so they're really sleep deprived on a chronic basis. Their respiratory system is out of whack, and so they're all over the place as far as their acid-base cycle. And then when all of those things start to happen, it's just, again, the snowball effect of physiology, behavior, and outcome start to happen. And they will come up with it. They will rationalize every aspect of this over and over again to make sure that, they're not at fault. And they're really not. But we tend, as a general society, to kind of blame them for these behaviors like they have control over. But when we start to look at, just the fundamental neuroscience behind what is causing these behaviors, such as, the signal going from an alpha and delta fire up to the brain, and then the way in which the body's supposed to control it, but yet we've circumvented that control by giving somebody an opioid, then ultimately this is not a patient-based behavior. This is something that gets developed because of a pretty definable set of physiologic realities that, when they fall in place together, really create a situation that it's untenable. it's really a huge problem. Sorry, I'm going to turn it down. There we go. So as we start to, to look at these things, we have to look at what am I dealing with? Well, one of the biggest things that I always tell people is you absolutely have to remember that behavior is a symptom, not a frustration. If they're behaving in a certain way, there's almost always a reason. And getting to that reason, if you have a chronic pain patient who start to have really these irrational, emotional, behaviors, that's generally a symptom that something's going on, much more than just that behavior. And so making sure that you address it, and just like a hypertensive episode, and if somebody comes in with a blood pressure of 220 over 120, we look at that because it's a vital sign. Well, a vital sign for chronic pain and addiction really is behavior. And so as they escalate their behaviors, we should be looking for what is the cause and effect of those behaviors. And that's tough sometimes because they will create just a complete havoc in an office or an emergency department. And they will start to pit people against each other. They will split between providers. They'll have all of these things happen. And all of that is basically because now they've regressed into an irrational survival mode, and they only see themselves being able to survive with these medications. And I think probably everybody on this call at one point or another has had a patient, if you ask the question, can you imagine yourself not taking an opioid? And they would look at you with like fear in their eyes, and their answer would absolutely be no. I can't even begin to imagine what that would be like. And that's where we end up with a lot of these. So what about when we stop the opioids? So let's say we talk them into it, or we force it. You're in a rural area. There's no other doctor who's going to write the opioids. You've already talked to the emergency room doc, and they're not going to fill the prescription. They're not going to give them an IV dose. So what's going to happen here? Or they say, I don't like this, I hate this, and I want to get off. Well, you're going to eventually return to baseline, as best we can tell. It takes a few months, though, for that to happen. And at first, though, everything is going to hurt. They're going to have basically a combination of central and peripheral withdrawal, along with just the fact that the spinothalamic tract is ramped up, the spinomesencephalic tract and the endorphin package is ramped down, and the spinal-reticular pathway is still ramped up. So they're still not going to be sleeping well. They're still going to have an overstated pain syndrome, and they're still not going to be producing their own opioids right away. So with that, they're going to be frustrated. And interestingly enough, because you've removed the opioid, their emotions are actually going to be more identifiable, but they're going to be very distinct. So even though they're irrational and all over the place with the other one, they will stick on an emotion longer in this setting. So you've taken them off of the opioid, so they've lost some of the lability, but they still have these other changes with the lack of sleep and that. So they may get angry, and they may be angry for a week, and not just like the moment of flipping back and forth. So I think that ultimately it's really important to know that as we look through the emotions and how they're distinct, the fear of pain, and this panic of, if I have that pain again, they're scared to death, and it's almost what we kind of call a pain PTSD. If they've had a severe pain in the past, then ultimately, we're going to have to figure out what we're going to do, for these patients, and let them know that we're not going to let them get back in that pain, but we're not going to use opioids, which that's the piece that scares them, and so it becomes pretty difficult. And as we do that, we have a number of different pathways that we can, look through with that. And some of these can be other medications, maybe flipping them quickly to a different opioid that maybe has less of a chance of causing these side effects or these changes in the brain. And we do find that something like a buprenorphine, which comes in many forms nowadays. I mean, there's a patch called Butrans you can use Suboxone or Subutex or Bunavail or Zubsolv, and then now there's an implantable version. And so that medication, being a partial agonist, does not seem to have the same effects as the full agonist opioid. So that one seems to be better in a way. It hasn't really been used extensively for pain enough for us to say that on a larger scale, and it still does affect these. There have been some functional MRI studies that have shown it to be relatively helpful. Now, methadone at daily doses, interestingly enough, has a lower risk of causing these same things. However, you're still going to get the spinal reticular piece, and that's why people in a methadone clinic for treatment of addiction will have a pretty persistent sleep disorder. It doesn't necessarily affect the spinothalamic tract because you're not trying to treat pain with it. You normally get these changes when you write for these meds in response to a chronic pain syndrome and not just for addiction. But let's talk about what happens, now. So the medication issues, the very real down to, ground level stuff that happens is they need early refills. So that should be just a rapid indicator. And either there are three reasons that patients generally need an early refill. They either overtook it, they're sequestering it, or they're selling it. And and in theory it could actually be stolen, but that's just rare, and then that keeps them from actually, saying that they can keep those medications in a safe place at home. But if they see several doctors and you check the cures report and you look at that and you find, wow, there's 4 doctors that have written for these medications. If they're taking more at once and you do pill counts and you come in and they're short on their pill counts. And they have this real abnormal attachment to the medications, and this is a very emotional aspect. And so this goes back to what we were talking about when we said they cannot imagine their lives without it. And then if they say, well, I ran out so I took some of my sister's meds, or I bought some from a friend because I didn't want to have pain. These are all behaviors that start to get in this very gray zone, of addiction. So I want to skip this slide for a second, run to this pain versus suffering, because I think that identifying the difference between actual pain coming from a signal that is being sent from an injury versus that spino-mesencephalic tract and the spinal reticular tract messing with the emotional centers of the brain to the point where they are overlapping the two. And suffering is very real to the patient, but the last thing that you want to do for treating emotional suffering, which feels like pain to them, is use an opioid. It's the last thing you want to do. These are patients who are worst pain ever, 10 out of 10, 20 out of 10, all of, the over-explanation of the pain. And a lot of that has to do with that suffering aspect of it. And most of the time, early on, you can go back to questioning them about, well, when you were a teenager and you hurt yourself, you sprained your ankle, did you get back to doing your normal stuff about the same rate as your friends, or did it take you a little longer? And interestingly enough, seeing how they dealt with pain early in life tells you if this is a person who at their baseline has a normal pain tolerance, or it's someone with a genetically lower pain tolerance. And that'll help as well, because you can normalize that. Well, you may feel pain differently, but now you're emotionally connecting to this pain. And that suffering aspect will really accelerate a lot of these pain behaviors. And that's the hardest part of this, is that these behaviors look a lot like addiction. And so when we look at these two pictures, while the colors may be different for structures, I mean, we're still looking at the anterior cingulate gyrus, nucleus accumbens, ventral tegmental area, amygdala, periaqueductal gray. And if you look at there, the only things really missing between addiction and pain are going to be the thalamus up here, because there's not really a signaling pathway through there. And then right here, the cranial nerve 5. Other than that, the central tenets and the central basis for how a patient is affected with addiction is a lot like the same way that we have. So let's talk a little bit about this area here. So this is the periaqueductal gray, ventral tegmental area, and nucleus accumbens. All right, so the reward system is really this ventral tegmental area and the nucleus accumbens. And the periaqueductal gray, this is interesting. So if a patient has actual pain and you give them an opioid to treat their pain, so they broke their leg and you give them pain, or they have a kidney stone and you give them a pain med, you're not going to light up the reward system, because the periaqueductal gray actually blocks the release of dopamine at the central part of the brain. The problem we get into is when people are taking pain medications without pain, because then you don't have that filter at the periaqueductal gray. And when that happens, you start to get a release of dopamine in that brain, which is really how we start to define a risk of addiction to a substance, is when you get this disproportionate release of dopamine. So as an example of that, if you have a patient who's going to go to physical therapy and they don't have pain yet, but you say, take your pain medicine before you go to physical therapy, that is a bad idea. It is a bad idea because that patient is, one, not going to get the appropriate feedback that they should, so they're going to be at a higher likelihood of injuring themselves during physical therapy. But also, they're not going to have that periaqueductal gray actually filtering that euphoric effect. And so what they're going to get when they take it with no pain is that euphoria, which then starts the whole mechanism of addiction. And so as we look at this pain to addiction, and this is where it starts. It's the taking of a medication that is either more than you need to take care of the pain, which would increase that dopamine, or you don't have pain and you take it to prevent pain down the road. Both of those things become really problematic. So if there's no pain, it doesn't filter. And if it doesn't filter, it starts to mess with the reward axis and really leads to what is the typical addiction neurobiology. So I know a number of you on the phone have probably heard me talk a little bit about addiction in the past, but I think it's important to go back over the fundamental aspects of how addiction occurs in the brain and what the neuroscience is of that. And we can do that pretty quickly. So if we think about addiction, I always use the terminology, we need three things to survive. Now the think tank at CHCF told me I should start being more accurate with that. And yes, we also need oxygen. But at the same time, the three things that I'm talking about is food, water, and dopamine. And we need dopamine because ultimately this is what's required to get you out of bed in the morning, to get up and get food and water. It's the thing that creates the connection between you and a loved one and you and your children. And it's the chemical in the brain that motivates you to do better things when you've done something good. When somebody pats you on the back because you've done a good job, it is that little bump in your brain that you get when you feel really good about an outcome from something. And so on a normal day, we're going to produce right around 40 to 50 nanograms per deciliter of dopamine. And we've done this through micropipetting studies and functional MRI studies to find out kind of the relative amounts of these. And so the normal day is right around 40 to 50. You know, your best day ever, the day you've won the lottery, you're sitting on a beach, 2% body fat, all that happens exactly at the same time. That ultimately is about 100 nanograms per deciliter. So that's the physiologic max that we're supposed to be at. Things like best food ever is about 94 nanograms per deciliter, and then sex, intercourse, about 92 nanograms per deciliter. So bummer there. I think they got to redo that study to figure that one out. But either way, that's what we're supposed to be at our physiologic max, is right up about 100 nanograms per deciliter. And that's your best day ever. So you need 50 to get out of bed in the morning and to be motivated to go to work and to do things during the day. And you can get higher than that with the dopamine if things are positive. But if it goes lower than that, then that's a problem. And if it goes higher than that, that's also a problem. So if we take something like a methamphetamine, then ultimately our baseline being 50 nanograms per deciliter, our best day ever being 100 nanograms per deciliter. Well, methamphetamine, if they use that, goes up to about 1,100 nanograms per deciliter. So now all of a sudden we've taken the nucleus accumbens and basically just beat it about the head and face and pushed it way up to this very high level of dopamine production. And with that, we have things like heroin that will go to 900, marijuana that's like 600, and all these other things that artificially raise dopamine. And when they artificially raise dopamine, then that creates a derangement in the reward system. And so over time, the body will, again, just like with pain, it's going to actually decrease the release of the substance. So in pain, it will decrease the release of endorphins, but in addiction, it decreases the release of dopamine. And so when you decrease the release of dopamine, you decrease your motivation. And then you decrease the production of dopamine. So now you can't even produce as much. And then without the substance, it makes it tough to even get out of bed in the morning. And then if that doesn't work and you continue to use the substance, the body will atrophy those nerves to the point where they can no longer even produce dopamine appropriately. And in the most extreme cases, it will kill those nerves through apoptosis, and then you can never get those back again. So for those patients, that ultimately helps to decide. So if you have craving for dopamine, when we talk about food, water, and dopamine, we know that craving for food, gives you about a baseball size of of desire and craving and the parts of the brain responsible for that when we look on a functional MRI. And water is about the size of a basketball. But if you look at what craving for the drug of choice is through functional MRI studies, it's the equivalent of the size of a baseball field. So it's factors of 10 higher than this. And so, things like alcohol that sit around, 700 nanograms per deciliter over time, the body goes down, 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 down. And now you have craving because you don't have dopamine because of the use of methamphetamine or heroin or alcohol or marijuana. And when you see that, you start to have the brain try to recompensate, and it can't. So it craves and it freaks out, and it thinks it's going to die, because if it can't get dopamine, then it's not going to be motivated to go get food or water or love or any of these other things. So when that happens, that ultimately this is what explains the behaviors that we see. So you have this lack of dopamine. You end up with a patient with significant craving. They then slip into survival mode. And if you have 10 times the craving for a substance than you do for water or food, we know what people are going to do for food or water. I mean, they will kill, they will steal, they will do all kinds of stuff to not starve and to be able to not die of dehydration. So we see with these patients that lack this dopamine and want it, we see this primal action. And that primal action a lot of times shows, these addiction behaviors, which oddly enough look a lot like the same behaviors that we see in pain, in chronic pain, with patients on opioids, which is this rapid escalation or changes in mood. Their emotions go from zero to 100, and they're not even aware that it's happening. To them, they've just normalized this behavior. They drop the keys on the floor, and they freak out. They have irrational thinking or behaviors that go along with this. And then again, the excuse is why the prescription wasn't turned in and why that wasn't done. And again, these behaviors are a symptom, and they are not something you should take personally. They're a symptom, not a frustration. And I think remembering that we diagnose addiction based on 9 behaviors and 2 physiologic phenomena. And so if they're meeting the criteria for those 9 behaviors and how they connect with the substance and how that impacts their interpersonal relationships, how that impacts their working relationships, how that impacts the decisions that they make about self-care and all of those things, it is interesting. And so when we start to look at these behaviors, they overlap so much that we have to know that the parts of the brain that are emotionally affected by opioids and chronic pain are the same ultimate parts of the brain that are affected in addiction. And so you take a person with a genetic risk of addiction who has chronic pain, and they take an opioid. It overcomes the periaqueductal gray. They get this bump in dopamine. But they also still have some pain, and so they're getting all of these other issues with pain that are coming up. They're still getting a spin up on their spinothalamic tract, which means they're still having pinpoint pain in their back. They're getting a spin up on the spinal-reticular tract, which means that they're not sleeping well. They're getting a spin up on the spinal-mesencephalic tract, which means the periaqueductal gray is decreasing even more the amount of endorphins that's being produced. And if for anybody who's a runner out there, a runner's high is caused by the periaqueductal gray releasing endorphins and cranking up the dopamine in the nucleus accumbens. It's a natural high. And so this is what the body has not able to do anymore once we've put a patient on chronic opioids. And when that happens, we ultimately create such many levels of dysfunction within the brain, both emotionally, physically, and ultimately dynamically, because they're not even able to assess normal pain anymore. And so these are patients who, if they're on opioids, won't shift in the couch if they're sitting there too long. And when that happens, they end up causing a pressure ulcer, or they end up creating issues in their spine otherwise. So these are all the side effects that we see. So I think the biggest issues are, we need to understand that there's a significant overlap between pain and addiction, and it really is a huge gray area right now. And in many ways, they're really exactly the same. And I think if you start to see your chronic pain patients who you would call drug-seeking, or your addiction patients who talk about pain, I mean, their behaviors mimic each other. I mean, it is in the mirror. And when I see them standing next to each other, I do believe that it really is a diagnosis without a distinction for these patients. And chronic opioids will absolutely exacerbate this risk, even if they have real chronic pain states, because of the dysfunction that it allows within the motional ability. And then if they overcome the periaqueductal gray, they're still going to see this lower dopamine, and they're still going to have that internal craving. And so the moral of the story is there are a lot of data that shows short-term utilization of opioids is fine. If you have surgery, 5 to 7 days should be fine. Most studies show that at 3 days you lose benefit. So the reality is, if you don't have to write it, don't write it. If you do have to write it for a short amount of time. Everybody in your office who's on chronic opioids should be evaluated for these behaviors and these dysfunctions. And if they find them, they do get better with the opioids, but that's when it takes it back to you have to set, expectations. And I have that around, there we go. Which means don't tell them you're going to get rid of their pain. Don't just, take this because it'll make you forget you even have pain. Or don't tell them, what you do need to tell them is we're going to decrease your pain and improve your function, and that's the goal. It is an increase in function, and you're going to get that increase in function if you can decrease, not eliminate, that pain. And if you don't see an increase in function shortly after the utilization of a medication like an opioid, then it should be stopped because it did not meet the required goal. But making sure that patients have these expectations set very early in their treatment is really important. Oops.
So, Cory, thank you so much. This is a great presentation, and we had some good questions come in. And 2 questions relate to different scenarios with you. Where you have someone who's dependent on long-term opioids. If they don't use any opioids at all, how long does it take for them to recover normal function? And if they do use Suboxone, what happens to all these behaviors?
Well, interestingly enough, utilization of buprenorphine for pain has been done in Europe for a while, and it was actually developed as a pain medication first in the early 90s. I would say there are no good longitudinal prospective studies on this, but anecdotally speaking, and this is a few hundred patients anecdotally, so it's not 1 or 2, I find that these behaviors are almost eliminated because you don't get the euphoric effect with the buprenorphine. And because it's a partial agonist and works as an antagonist in the kappa receptor, it actually does not seem to decrease the amount of endorphin released from the periaqueductal gray because of what it does on the kappa receptor. So as a medication, physiologically and pharmacodynamically, it seems to really align well with exactly what we would want in a medication. And so ultimately, if the patient has overt opioid addiction or poorly controlled chronic pain and they're on an opioid and we need to get them off, or an overlap of those two, the answer still seems to be one of the buprenorphine products could be a good stepping stone to getting them completely off. The return to function is going to depend on if they have an injury, if that injury has been, if they've had significant chronification of that injury and imprinting in the brain. Because sometimes Dr. Apkarian at University, he's at Northwestern in Chicago, he's done some really interesting studies on acute pain turning into chronic pain. And basically what he showed was that you can imprint the pain signal into the thalamus and create a central pain syndrome for chronification. And so you can have 0 signal coming from the back and nothing going through the spinal thalamic tract and still have a sensation of pain because it imprinted inside the thalamus. And so what you're getting is basically a false signal coming through the thalamus. And so if that has happened, that becomes central pain syndrome, and there's a good chance you're not going to be able to fully get the pain away, and then you have to work on the behavior modification so that they can live at some level with the pain that they have.
Well, thank you. This is got another few comments, a very helpful presentation to understand complex neurobiology in a simple way. For those of you who are interested in the research on buprenorphine for pain, we had so many questions about this on previous webinars. We've summarized as much as we can find about buprenorphine for addiction and pain, put it into a frequently asked questions document on our website. If you go to www.chcf.org/OSCN, or you go to our website and Google buprenorphine, you'll find this document, and it covers the research for pain, the use of patch induction, so you can take people from their opioids onto buprenorphine without doing much of a severe withdrawal. And this is, again, why we brought Cory Wyler here, because there's so much published now about opioids that we're seeing a big backlash and doctors refusing to prescribe at all, or suddenly cutting people off of opioids after long-term use, or becoming very aggressive about urine drug screens. But when you look at what the evidence shows about how to lower overdose deaths, we found it's 4 simple things. It's being very careful about new starts, as Dr. Wyler said, limiting to a few days, and being very judicious about the people you put on long-term chronic opioids. Focusing on the people who are on high-dose opioids or who have addiction, because those are the ones who are going to be harmed by opioids. And if someone's been on long-term opioids, it's low dose and doing fine, that may not be the right place to start. And we worry that there's going to be harm when elderly people on a couple Tylenol, codeine a day, or switch to ibuprofen. We're going to focus on where the people who are having overdoses and harm. It's on those on high dose, on combo with benzos, or those addiction. And finally, to make sure that addiction is identified and medication-assisted treatment is available as of naloxone. I did get a comment about adjunctive therapy and complementary and alternative medicine, and we're going to be publishing today a case study on different community clinics across the nation that have used complementary therapy for people with chronic pain and how they've managed to pay for it, because some of the people in the safety net have difficulty accessing these treatments. So again, if you go to our website, there's information about buprenorphine in primary care and the emergency department, and non-opioid actions for chronic pain. So again, thank you, Dr. Wyler, great presentation. We will send out this link next week with the resources that I mentioned today, with slides that will be available to you, with the recording. And again, we thank you for joining us today. We had a great presentation. Take care.
Great. Thank you.